you have the management of pain started. So today what we'll be dealing with would be, next slide please, the opioids in detail. So the discussion topic for today would include the commonly used opioids, the mechanism of action of opioids, the practical aspects of opioid use, adverse effects of opioids, and the price of different opioids. So next slide. I hope you all are familiar with this. Can somebody tell me that? Can somebody talk about or comment on the WHO analgesic ladder? You can either unmute and speak or type in your chat box. So as you see, this is the WHO analgesic ladder of cancer pain management. And as you might have already gone through this step 1 of WHO analgesic ladder deals with non-opioids plus or minus adjuvants. And if the pain is persisting and still increased, then we move to step 2 of the WHO analgesic ladder. And the step 2 includes opioids for mild to moderate pain plus or minus step 1, which includes non-opioids plus or minus adjuvants. And if the pain is even more severe, then we move on to step 3 of the WHO analgesic ladder. And the step 3 of WHO analgesic ladder includes opioids for moderate to severe pain, plus or minus non-opioids, plus or minus adjuvants. And I understand you have so far completed sessions till step 2. So today we will be dealing more on step 3 opioids. So I'm requesting all of you to please interact. This would be a good learning experience if you interact. It will be a mutual learning, and mostly this session would be like description of patient stories and how to handle how do we handle such situations. So I would request you to either unmute and talk or please type in the chat box, and so that it would be helpful for you. It would be much more helpful for you. So we'll begin with a patient scenario. Suppose in your OPD, you have a 56-year-old man who was diagnosed with carcinoma of larynx, and you assess the pain. So you have already gone through the PQRST of pain assessment, and you understand the site of the pain is around the neck, and with the pain score of 10 on 10 with a sharp, not a radiating kind of pain, which has been lasting since 2 weeks, and the patient is unable to sleep because of this pain. How will you manage this pain? I would like to hear from the team. How do you manage this pain?
Participants, please type your comments in the chat box and I can read it out for Dr. Amirtha.
So this is a patient with severe pain, 10 on 10 pain, and the description of the pain is given here. And the pain is so severe that he is unable to sleep since 2 weeks.
So ma'am, we are getting comments. Dr. Dilip is saying we will start with tramadol and paracetamol. Dr. Kurt is saying, can the patient swallow oral medication? And she's asking a question. And Dr. Ravindra says we can give tramadol with clonazepam.
Yeah, so thank you all for the responses. So we have already seen the WHO analgesic ladder, and depending upon the severity of the pain is how we make decision on which step of the analgesic ladder we should prefer or we should choose on. And as you understand, the intensity, or as per this patient story, the intensity is 10 on 10 pain. So what does that indicate? Which step of the analgesic ladder should we opt for a patient who presents with 10 on 10 pain? Any comments or responses?
Dr. Bindurani says step 3. Dr. Dilip Pawar says moderate to severe. Dr. Upakul says step 3. So we are getting more comments on step 3, ma'am.
Thank you. Yes, you're right. So as you rightly said, we'll go with the step 3 of the analgesic ladder. So now we understand that the patient is on severe pain, 10 on 10 pain, and we need an immediate relief to the patient. So what could be our next step to bring in an immediate relief to the patient? Anybody has any idea? Yes. So
Dr. Bindurani says we can use morphine.
yes, doctor. So step 3 opioids includes morphine, fentanyl, methadone. These are the commonly available step 3 opioids with us. And so yes, morphine is a good choice here. So now the question is that, as I said, we need an immediate relief to the patient. So how can we go about this? So we can do a procedure known as intravenous morphine titration. So how do we go about this procedure? Intravenous morphine titration. So it is a procedure in which the patient with immediate pain is given injections. The morphine is diluted and then it is given an injections in 10 minutes interval. So how do we go about that? One ampule of morphine contains 15 milligram of morphine. So this one ampule is diluted and then with 9 ml of normal saline and made up to 10 ml of the diluent. And 1 ml, so in such a way that 1 ml contains 1.5 milligram of morphine. So this 1 ml is given to the patient in every 10 minutes interval through the intravenous route. This is known as intravenous morphine titration. So this can be done as an outpatient procedure where the patient can be given intravenous morphine injection. So I would repeat the dilution. So 1 ml of ampule or 1 ml, 1 ampule of morphine contains 15 milligram. So this 15 milligram is diluted in 10 ml and the dilute as such that the diluent 1 ml of the diluent contains 1.5 milligram of morphine. And this 1 ml is given in every 10 minutes interval. So this is how the process would be. And since this morphine, what is the immediate side effect that we can expect with morphine?
Respiratory depression.
Any other responses?
Dr. Vincent says vomiting.
Yes. Yeah, thank you. Thank you for that response. Yes, nausea and vomiting is one of the most immediate side effect of morphine that we can expect. So keeping that in mind, before starting the titration process, we would start with injection metoclopramide 10 milligram IV. So the patient should be given. So once we prepare the patient for the morphine titration, we'll check the vitals, then we'll be checking the respiratory rate, and we'll be assessing or recording the pain score of the patient. So this patient, the pain score is 10 on 10 and the patient will be given injection metoclopramide 10 milligram IV stat. And after that, we'll start with the morphine titration process. And 1.5 milligram or 1 ml of diluent would be given and the time would be recorded. Next slide, please. So suppose the titration process started at 10 o'clock, we'll be recording the vitals of the patient and the most important is the pain score, 10 pain score. And what would be the endpoint of our titration or when do we stop this titration process? So the endpoint of the titration would be either the patient becomes drowsy or the pain score comes down. So which one happens first would be the endpoint of the titration. Either the pain score comes down or the patient becomes drowsy. So that would be the endpoint of the titration. So this patient was started at 10 o'clock. 1.5 milligram of injection morphine was given when the patient had a pain score of 10. Then after 10 minutes, again reassess the pain score. It is 7/10. patient is still not drowsy, record it, and another 1.5 milligram of injection morphine is given. Wait for another 10 minutes, reassess the pain score and the vitals, and see if the pain score has come to 4. And still the patient is not drowsy, so 1.5 or another 1 ml of IV morphine is being given to the patient. And next, wait for another 10 minutes and reassess the pain score and the vitals and see if the patient is still not drowsy, but the pain score has become 1/10. And this would be the endpoint of the morphine titration for this patient. So this means that in every 10 minutes, we have given the patient 1.5 milligram of dose. So 3 doses were given. That means that 4.5 milligram of IV morphine was given to the patient in 10 minutes interval. So now the pain score has come down and we are stopping with the morphine titration. Suppose this patient wants to go home. What do we do? How do we send the patient home? It is not always practical to send the patient on IV morphine. So what do we do?
Yes, very right. Or even fentanyl patch.
Yeah. Thank you. Thank you for that responses. So yes, as you said, oral morphine could be a choice. Next slide, please. So now we have to convert this 4.5 milligram of IV morphine. Since the patient has good pain relief, we are converting it to oral morphine. So what is the conversion ratio? So usually after morphine titration, IV morphine titration, the conversion ratio would be 1:1. So the ideal dose with which we can send the patient home would be 4.5 milligram oral morphine. So what we do is that the nearest available dose, so that is 5 milligram of oral morphine. So the patient would be sent home with the 5 milligram of oral morphine. That is, as we have learned in the principles of analgesic ladder, always prescribe the medications by the clock, by the mouth, by the ladder. So we have assessed the pain and we are giving the medications by the clock. What do you mean by the clock? So for this patient, the morphine is given every 4 hourly. So 5 milligram of morphine, since the titration was 4.5 milligram of injection morphine, we are converting it to 5 milligram of oral morphine and we are sending the patient on 5 milligram 4th hourly of oral morphine. So that is 5 milligram 6 a.m., 10 a.m., 2 p.m., 6 p.m. And at bedtime, we are giving double dose. Why do you want to give double dose at bedtime? Any comments on that?
Patient shouldn't sleep shouldn't be disturbed because of pain.
Yes, thank you. Thank you for that response.
Plus it will be 8 hourly plus.
Sorry.
I mean the
Pardon,
sleep
Dr. Nathan? We couldn't hear
sleep
you
hours will be more than 4 hours, right?
Yeah, so actually, one of the reasons is that we don't want to, so that morphine takes around 4 hours. Every 4 hourly, we are giving the patient morphine. But we don't want to wake up the patient at 2 a.m. and give him another dose of morphine. But the patient should be pain-free also. So we are providing the patient with double dose at night so that the blood level of the morphine is being maintained throughout the night so that the patient have adequate pain relief throughout the night. So this is one of the reasons why we are providing the patient with double dose at night. And when we prescribe morphine for patient, we write it as tab morphine. If it is 10 milligram or 10 milligram, we write half Q4H, or we can write it as tab morphine 5 milligram Q4H and 10 milligram HS plus 5 milligram as SOS. So the patient will be instructed to use 5 milligram of oral morphine as SOS dose as and when required if the pain relief is not satisfactory. So next slide. Suppose the patient comes to a setting where we don't have an IV morphine. So we don't have morphine ampule, we only have oral morphine. How do we go about it? So we can do oral morphine titration. How do we do oral morphine titration? So if it is a patient who's new to opioid, we would start with 5 milligram of oral morphine. So 5 milligram every 4 hourly with 10 milligram HS dose and 5 milligram as SOS dose. Suppose the patient is already on a weak opioid like tramadol or tapentadol, what would be our choice? We can start the patient on either 7.5 milligram or 10 milligram of oral morphine. So the patient's already on weak opioids, we can start with 10 milligram Q4H of oral morphine. And if the patient is new to opioid, the starting dose preferably is 5 milligram Q4H. So next slide, please. So we're continuing with the patient story. So Mr. X, who has come to us with severe pain, was done IV morphine titration. And as per the IV morphine titration, the patient was started on oral morphine 5 milligram 4 hourly and also SOS dose. And he was sent home. And what the reports we got were that he was relatively pain-free. For 2 weeks, he was having satisfactory pain relief. But since last 4 days, his pain relief was not that satisfactory and he had to take rescue doses or extra doses of morphine at the rate of 3 doses per day. What shall we do now? How do we handle the situation? Any suggestions on that?
We increase the dose from 5 milligram to 7.5 milligram for hourly.
Thank you. Thank you, Dr. Soma, for that. Yes. So what does this indicate? This indicate that the pain relief is not satisfactory, means the dosage is insufficient. And as you rightly said, we have to increase the dose. So how do we increase the dose? So when a patient is taking 2 or more rescue doses of morphine, which is a clear indication that the dose is insufficient, we can, in a 24 hours time, we can increase the dose by 30 to 50%. So that means the patient can be started either on 7.5 or 10 milligram of oral morphine every 4 hourly. So we can increase the dose to 7.5 or 10 milligram every 4 hourly. So we had one more question in that slide. How frequently would you give the SOS dose of oral morphine? Any comments on that? So in between, every time I was talking about the SOS dose, we need to give SOS dose of morphine. So how frequently can we use this SOS dose of morphine?
Dr. Ravindra says 3 times.
Could you explain why?
Dr. Rosa says when there is severe pain once.
Thank you. Thank you for that responses. But to understand this more, we need to learn a bit more about morphine. So we'll be learning a bit more about morphine. So morphine, it is a naturally occurring opioid and it is extracted from the opium, named as Papaver somniferum. So the generic name is Papaver and somniferum is a Latin word which means inducing sleep, sleep inducing. So morphine is being extracted from the pods of poppy plant and it is legally permitted to cultivate. In India, the cultivation happens in Madhya Pradesh, Uttar Pradesh and Rajasthan. These are the 3 states that is legally approved to cultivate morphine. this poppy plant. And more into the pharmacokinetics of morphine, we'll be looking into the details of absorption, distribution, metabolism, and excretion. So first, to begin, how is morphine absorbed? Next slide, please. So morphine is a weak base, and when taken orally, it is absorbed from the upper part of the small intestine. And since it is hydrophilic in nature, the onset of action is slow and it has longer duration of action. So, and the other routes, that the sublingual route, the absorption is very low through the sublingual route. And evidence says that the buccal and gingival absorption, also the evidence are very less or very, like we don't have much evidence about the absorption through the buccal and gingival route. And also morphine is found to have a bitter taste. So it is mostly preferred route is through the oral. Oral route is the most preferred route. And how does morphine undergoes metabolism? So morphine, once it is taken orally or swallowed, it reaches the gastrointestinal tract, from where it is absorbed into the blood vessels. It enters the portal vein circulation and reaches the liver. In the liver, it undergoes metabolism and the metabolites are released into the systemic circulation. So though the majority of metabolism takes place in the liver, there is some amount of metabolism that is happening in the gastrointestinal tract as well as in the kidney. Around 90% of the morphine is converted to its metabolites, and the active metabolites are morphine 3-glucuronide and morphine 6-glucuronide. Around 45 to 55% is morphine 3-glucuronide, which is responsible for the neurotoxic effects of morphine, and 5 to 10% is morphine 6-glucuronide, which is responsible for the analgesic effect of morphine. So we are more concerned with the morphine 6-glucuronide that produces the analgesic effect of morphine. So, next slide. So this whole process, it takes around 45 minutes to 1 hour for morphine to peak its action in the body, and for the metabolism to take place in the liver and metabolites to get released into the systemic circulation. So when given orally, morphine takes around 1 hour to produce its effect, peak effect. And so when SOS dose of morphine is being given, there should be an interval of at least 1 hour between two SOS doses. So that means that suppose a patient is on morphine, 5 milligram of oral morphine every 4 hourly. You give the patient at 6 a.m. 7 a.m. the patient reports that the pain relief is not adequate. If the patient reports at 6:30 a.m., we'll wait for another half an hour, and still the pain relief is inadequate at 7 a.m., we can give one SOS dose of morphine and wait for another 1 hour for the morphine to produce its peak analgesic effect. And once after 1 hour, if still the pain relief is inadequate, we can think about giving an additional dose of morphine again. But what we need to keep in mind is that we need to watch for the toxic effects, and as well as there should be a gap of at least 1 hour between each dosing. I hope this is.
Ma'am, one question from Dr. Kurt. So what would be the difference between SOS dose and rescue dose?
So it is the same, just synonyms, we can call them as synonyms. It's the same, that the dose which we give other than the regular dose, the dose that we provide in between to produce adequate pain relief. Yes. So we are moving on to the next patient story. So I'm sorry, it's the same patient whom we have started. So now, since the pain relief was not adequate, we started him on 10 milligram of morphine every 4 hourly. But now the issue is that he finds it difficult to take it every 4 hourly. He still understands that it is important to take morphine for pain relief and is willing to take it. but he is requesting if something can be done to reduce the frequency at which he needs to take the medicine. Are there any suggestions? What can we do for him? How can we help him?
Sustained release. We are getting comments saying sustained release, add step 1 drug, extended release tablets.
Thank you. Thank you so much for the responses. Yes, sustained release morphine would be our next choice. So what is the difference between sustained release morphine and immediate release morphine? So the immediate release morphine, if the duration of action is for 4 hours. And as you see that by the clock, when we prescribe, it is every 4 hourly we give the medication. The sustained release morphine, the duration of action is for 12 hours. So the patient needs to take the medication only less frequently. That is, the patient who was on 10 milligram of oral morphine every 4 hourly, that means that the total dose of morphine in 24 hours is 60 milligram. So the total dose 10 milligram every 4 hourly, that means 6 times a day. So the patient is taking 60 milligram of oral morphine in 24 hours. So this intermediate release preparation can be converted to sustained release preparation. That is, the patient can be given 30 milligram of sustained release morphine 2 times a day. So that will solve his problem. So next, so having said that, now we learn about the preparations of morphine. Morphine is available as aqueous solutions. That is, it is available in the syrup form. It is also available as tablets. And as I already said, the tablets could be immediate release tablets or sustained release tablets. And also it is available in the injectable form. So now moving on. So the patient, he is still on 10 milligram of morphine 4 hourly for the past 6 months. And now he was brought to us. He was presenting with excessive drowsiness. And on examination, we found that his serum creatinine was 5 milligram per deciliter. So, do we have to do anything with the morphine dosage? Or what would be our next step for such a patient who presents with excessive drowsiness? And we found that his serum creatinine is 5 milligram per deciliter.
So we are getting comments saying step 2. Anything else?
Why do you want to go to step 2?
Dr. Bindu says ketamine. Dr. Raisha, would you like to comment on that by unmuting yourself?
So to understand more on,
Excessive drowsiness.
yeah. Yes, doctor.
Due to excessive drowsiness, maybe he doesn't need that much dose.
So what could be the reason for this excessive drowsiness? Why could he be presenting with this excessive drowsiness? To understand that more, we'll have to learn about the excretion of morphine from the body. So we just went through the absorption. We also learned about the metabolism. Now the metabolites are in the systemic circulation now. How is the excretion happening for morphine? So morphine is excreted by glomerular filtration. So excretion is through kidney. And what happens in renal failure or when the serum creatinine is high? The morphine 6-glucuronide, which is responsible for the analgesic effect of morphine, gets accumulated in the blood. And as a result of this, because the patient is having renal failure, the clearance of the drug from the body would be decreased. And hence the availability of the drug in the body will be prolonged. Since the half-life is prolonged, the medication or the morphine would be available in the body for longer duration of time. And so what can we do about it? we have to either increase the spacing between the doses or like making the dose. So the patient is on every 4 hourly, you can either make the dose 3 times a day, or you can reduce the dose, or we can go for alternative opioids. So when a patient presents with renal failure, that indicates that since the excretion of morphine from the body is through kidney, it indicates that the morphine gets accumulated. The metabolites of morphine is getting accumulated in the blood, and the clearance is delayed or decreased. So either increase the spacing between the drugs, like the frequency should be reduced. If it is 4 hourly, you can convert it to 3 hour, like thrice daily or twice daily, depending upon the toxic response to the pain and toxicities. Or you can reduce the dose as such. Suppose the patient is on 10 milligram, you can reduce the dose to 5 milligram, or you can switch it to renally safe opioids. So this could be the 3 options in patients with renal failure when you start with morphine. Hope I'm clear.
Dr. Aisha, I can see that you have raised your hand. Would you like to
Okay,
ask?
ma'am, you are told no, only 4 hours duration, the oral morphine immediate release morphine action time is duration of action 4 hours. So when we increase the space, will it affect the pain?
Thank you so much for that question, Dr. Reza. So obvious, if it was not for renal failure or if the patient's excretion was normal, then it would have affected. But since the excretion is affected, like the due to the renal failure of the patient, the analgesic will be, the metabolite will be more in the blood. Since the morphine 6-glucuronide, which is the metabolite which is responsible for the analgesic action of morphine, the clearance is delayed or decreased, and this metabolite will be available in the blood for longer duration. And because of that, this can produce the analgesic effect. Even though we increase the spacing between the doses, like if we don't provide 4-hourly dose also, the patient can have adequate analgesic effect. I hope is it clear? Okay, yes. Yeah. Thank you, Reza. So how can we send this patient? So this patient was having a serum creatinine of 5 milligram per deciliter. So we have sent him home on 5 milligram 8 hourly. So we have reduced the dose as well as we have increased the spacing between the medications. So the patient is currently on 5 milligram 8 hourly, and the patient was having an advanced cancer. So the disease was progressing, and the physical condition is deteriorating, and after 2 months, the patient is in a stage where he is unable to swallow anything. And he was finding it difficult to take the medication also orally. And he is at home. What will you do now for your pain relief of the patient? How can we help this patient? The patient wants to be at home. He needs pain medication, but he's unable to swallow. Can we do something to help the patient?
Dr. Kalyani says morphine suppositories or fentanyl patch. Dr. Abhishnaik says topical preparations. Dr. Kurt says fentanyl patch. We are getting more answers on fentanyl patch. Injectable morphine. Dr. Abhish says injectable morphine.
Thank you. Thank you for all the responses. Yes, these are options. Fentanyl patch, later in the session, we'll be dealing with the fentanyl patches. So we'll be slightly touching upon the advantages and the disadvantages with the fentanyl patch also we'll be checking. And at home, injectable preparations could be a bit difficult for the patient. So to answer this, we need to know the routes of administering morphine. So what are the different routes by which morphine can be administered? So we have already said the most preferred route for any analgesic would be the oral route. Then other than oral route, we have also seen the intravenous morphine titration. So morphine can be given intravenously as well as subcutaneously. What are the other routes of administering morphine? So morphine can be given through the perrectal route, it can be given through epidural, and it can be given through intrathecal. So these are the various routes of administering morphine. So coming back to the patient story. Next slide, please. The patient, can somebody answer, how can we help this patient? So the patient is unable to swallow anything.
Dr. Aisha, I can see that your hand is still raised. Do you want to unmute and ask something?
Ma'am, if the patient is on Ryle's tube, can we give the morphine through that, like by powder, making it as powder? Is there any difference in action?
Yeah, thank you, Dr. Aisha, for that question. So, yes, if the patient is on a nasogastric tube, the patient can be given powder preparation orally. So, I see some more responses.
Yeah, Dr. Dilip is saying is rectal easy. Dr. Kalyani says oral injectable topical suppositories.
Yeah, thank you. Thank you for that responses. Yes, Dr. Dilip, rectal can be given morphine. It would be, if the patient is willing, it would be the ideal route for the patient at home when he is unable to swallow orally. So the same oral tablet, it can be mixed with a drop of water made into a paste and applied on the rectal mucosa. The absorption is almost comparable with the oral preparation, and the patient can have adequate pain relief with that. So that would be the best choice for this patient. 5 milligram of per rectally every 8 hourly. That would be the immediate release preparation that we give. The same oral preparation can be used per rectally every 8 hourly. I hope it was clear so far. So now we are moving on to the next patient story. So this is Mrs. K. So we had a 55-year-old lady with carcinoma of colon who had abdominal pain which was continuous in nature. She was on oral morphine 10 milligram 4 hourly, and her pain was well controlled and was not requiring any rescue doses in between. So her doctor has asked her to replace morphine with 25 microgram of fentanyl patch. But the patient came to us telling that since she had no pain relief, she had removed the fentanyl patch after 5 hours. So what will you do? Any comments on that? Okay, so to know, or maybe we'll learn a bit more about the fentanyl patch. So what is how does the transdermal fentanyl patch act? So the transdermal fentanyl patch, it is usually applied on the intact skin. So the patch should be kept on the intact skin with no abrasions, and it should not be kept on the skin that has been shaved, because there will be micro abrasions present which can affect with the absorption of the drug. And also temperature can influence the absorption of the drug. So the transdermal patch should be placed on intact skin. And how does this transdermal fentanyl patch act? So it forms a subcutaneous depot of the drug, and it slowly releases the drug from this depot into the circulation, into the systemic circulation. So, and it takes around 8 to 12 hours for the fentanyl patch to produce effective analgesia. And the patch, so one patch can be kept for 3 days. And the most important is that fentanyl patch is suitable only for patients with stable pain relief. Because when we say a 25 microgram of fentanyl patch, it means that 25 microgram of the drug is released per hour. And this will be a constant release. So if the patient is having in between breakthrough pain, we cannot do anything about that. So only patients with stable pain relief, we prefer fentanyl patch. And fentanyl patch it is available as injections, it is available as transdermal patch, and also it is available as oral transmucosal fentanyl citrate. It is lipophilic in nature and it is around 100 to 150 times more potent than morphine. And 60 milligram of oral morphine in a day is equivalent to 25 microgram per hour of fentanyl patch. What does that mean? A patient who is on 10 milligram of oral morphine every 4 hourly, if the patient has stable pain relief and the patient is unable to take morphine orally, and of course, the patient is from a good financial background, and we want to convert him to fentanyl patch, the ideal dose at which we can start the patch would be 25 microgram per patch. So this 25 microgram of fentanyl patch means that 25 microgram of fentanyl is being released every hour. 25 microgram per hour. And this single patch, it acts for 72 hours. That's 3 days. The same patch can be kept for 3 days.
Here, Dr. Dilip is asking a question. Is fentanyl patch very costly?
Yes, Dr. Dilip, it is really expensive. I'll be walking you through the comparative prices of different opioids towards the end of the session. That is what I mentioned. If the economic status of the patient is stable enough or affordable enough, then only we should suggest for fentanyl patch. So next we have a 70-year-old man with carcinoma of the lung, and he is complaining of a continuous kind of pain in the right front of the chest, which is throbbing in nature, scoring around 5/10. He is a non-epileptic and he is on levetiracetam, 500 milligram twice daily. What would be the right choice of opioid for this patient?
Dr. Dilip says paracetamol. Dr. Abhishek says tapentadol. Dr. Ravindra also says tapentadol. Dr. Dilip says we should avoid tramadol. Aditi says paracetamol first. Dr. Kurt says step to drug that has anti-epileptic effect. Thank you for all those comments.
Yeah, thank you for all the responses. Yes, so as you said, the pain score is 5/10, which means that it's a moderate pain. Preferably step 2 opioids would be the right drug of choice, but see, the step 2 opioids includes tramadol, tapentadol. Both of them are known to reduce the seizure threshold. So a patient who's non-epileptic or who's on anti-seizure drug, it wouldn't be safe to start on a step 2 opioid like tramadol or tapentadol. So preferably it would be a low dose of step 3 opioid. Morphine on a lower dose would be most preferable. So now moving on to what are opioids. So there are the two main characteristics of opioids are that they combine with the opioid receptors to produce their effects. So the drugs that combine with opioid receptors to produce their effects, as well as if their action is antagonized by naloxone. So these are the two characteristics of opioids. They can be naturally occurring, semi-synthetic or synthetic drugs. They combine with the opioid receptors to produce their effect, and their effect can be reversed or antagonized by naloxone. So what are the opioid receptors? We have mu, kappa, and delta are known as opioid receptors. We have sigma, but it is not considered as a true opioid receptor because its action is not mediated through or not reversed by naloxone. So next slide, please. So based on the receptor interaction, the opioids can be classified as agonist, antagonist, and agonist-antagonist. What do you mean by an agonist? An agonist means a drug which combines with the opioid receptor and produces effect is known as an agonist drug. For example, morphine is a mu agonist. That means that morphine combines with the mu receptor and produces the analgesic effect. So that is an agonist. What is an antagonist? An antagonist is a drug which binds with the receptor site and displaces the agonist from the receptor site and reverses the action of the agonist. That is antagonist. So this antagonistic drug does not produce an effect of its own, but it prevents the agonist from producing its action. So naloxone is an opioid antagonist. That means that naloxone displaces morphine from the mu receptor site and binds with the morphine and nullifies or prevents the morphine from producing its effect. So that is an antagonistic drug. And we have agonist-antagonist. That means at certain receptor sites, they produce agonistic effect, and at other receptor sites, they produce antagonistic effect. So this agonist drugs means even if you increase the dose of agonist drugs, their pain relief also increases. So that is that steady line indicates that with increase in the dose of the drug, the pain relief also increases. But agonist-antagonist means initially with the increase in dose of the drug, the pain relief increases, but at a stage beyond which, even if the dose is increased, the pain relief there will not be much change in the pain relief. So that is agonist-antagonist. So agonist drugs, they don't have a ceiling effect. And the agonist-antagonist drugs, they have a ceiling effect. That means increasing the dose beyond a point will not produce much difference in the analgesic effect. So pentoxin is an example for agonist-antagonist. So what do you mean by agonist and antagonist is that pentoxin has an agonistic effect on the kappa receptors and it is a weak antagonist in the mu receptor. So it acts as an agonist at certain receptors and antagonist at other receptors. So pentoxin, morphine, as I already said, is a mu agonist. So pentoxin will replace morphine from the mu receptor site. So that is agonist-antagonist. So a drug which has agonistic action at certain receptors and antagonistic action at other receptors. So pentoxin is an example of such a drug. Now, moving on to the side effects. So adverse effects can be classified as side effects and toxic effects. So side effects means these are adverse effects with the therapeutic doses. So with the therapeutic doses, if there are adverse effects occurring, they are known as side effects. What is the most common side effect of opioids? Can somebody?
Nausea.
Nausea. Constipation. Thank you. Thank you for the responses. So the most common side effect of opioids is constipation. Almost 90% of the patients, 95% of the patients who are started on morphine will develop constipation. And this constipation will be As long as the patient is on the opioid, this will be a long-lasting side effect. So when a patient is started on opioids, make sure that a stimulant laxative is being added. Bisacodyl or sodium picosulfate needs to be prescribed along with the morphine, anticipating that there are chances of the patient developing constipation. The other side effect that can occur is nausea and vomiting. 1/3 of the patients can develop nausea and vomiting. But this is a self-limiting symptom. The patient within the first 3 days, usually within 3 to 5 days, the patient will overcome with this symptom. It is a self-limiting symptom. So, and this vomiting and nausea is mainly because of the stimulation of the chemoreceptor trigger zone. So what is to be done is that if you remember, during the morphine titration, we gave the patient injection metoclopramide. So similarly, drugs acting on the chemoreceptor trigger zone, like the haloperidol, metoclopramide, domperidone, should be given to the patient for initial 3 days when we start with the morphine. So along with opioids, an antiemetic like haloperidol, metoclopramide, or domperidone needs to be started for the initial 2 to 3 days. And since this is a self-limiting symptom, after that we can stop the medication. Then other side effect is sleepiness and tiredness. So this is also a self-limiting symptom. So we need to communicate or inform the patient that there are chances of developing sleepiness and tiredness. But if this doesn't get over in 2 to 3 days, then we need to know about it, or the patient should inform us. The other side effects of morphine include itching, dry mouth, urinary hesitancy, etc. So next will be the toxic effects. So these are adverse effects when the administered dose is higher than that is required for the pain relief, or if the pain is not an opioid responsive pain. In such situation, the patient can develop toxic effects. What are the most common toxic effects? Delirium, myoclonus, and drowsiness are the most common toxic effects that we see in patients on morphine opioids. So, next slide. Does opioids produce respiratory depression?
Only very high dose.
Sorry,
In high doses, ma'am.
in high doses.
Dr. Amirtha says yes.
Does everybody feel the same?
Yes.
Yes. Thank you. Thank you for the responses. So I have been into palliative care since 10 years. And in my experience, I have never seen a patient on respiratory depression due to oral morphine. So when these medications are given by the mouth and the dose is increased, the dose is monitored, well monitored and cautiously and wisely administered, there are very less chances of developing respiratory depression. Hardly I have not seen any such cases. So by the mouth, by proper monitoring of toxic effects and the pain relief, if you titrate the dose, there are very less chances of developing respiratory depression. But there are situations where respiratory compromises can occur. And these are situations usually when the patient has issues like pneumonia or pulmonary embolism or cardiomyopathy, or the patient is prescribed along with benzodiazepine-like drugs. Those are situations where such respiratory compromises are happening. But otherwise, if it is given, well monitored and cautiously titrated, there are very less chances of developing respiratory depression. Next slide, please. Does opioids cause addiction?
Yes, very much.
Very much. Everybody agrees with Dr. Dilip?
Yes.
So let's see what the evidence are telling. Next slide. So the substance abuse as a result of medical use is very low. And always the risk of addiction is overestimated by the healthcare professionals. Actually, the professionals, they overestimate. And due to this overestimation, we are a bit hesitant or afraid to prescribe the medications as per the need. And also, there is a confusion between physical dependence and psychological dependence. So, what is physical dependence and what is psychological dependence? So, according to the American Pain Society, American Academy of Pain Medicine, and American Society of Addiction Medicine, psychological dependence or addiction, it is a neurobiologic disease with genetic, psychosocial, and environmental factors which influences its development and manifestations. There will be impaired control over the drug use and continuous use despite harm and craving for the drug. So this is how the American Society of Addictive Medicine describes psychological dependence or addiction. And what is physical dependence? It is a state of adaptation that is manifested by a drug class specific withdrawal syndrome. So it usually presents as withdrawal syndrome. So how many of you drink tea or coffee? Maybe tea. How many of you drink tea in the morning?
Yes,
Is it compulsory that you should drink tea? What would happen if you do not drink tea? Dr. Dilip?
so if I don't drink, then it feels something is missing.
Your voice is breaking, Dr. Dilip. It is not very clear actually.
We feel that something is missing if we don't drink.
Okay.
So Dr. Uroza says it's all psychological. Dr. Aditi says it is addictive. Dr. Sheetan says she will develop headache.
Yes. So suppose Dr. Dilip is out of stock of tea leaves, but he is badly in need of tea. So morning, so he stays near Dr. Priyadarshini's flat and he understands that there is tea leaves in in Dr. Priyadarshini's kitchen, but she is not there. So what does Dr. Dilip does is that he breaks open her kitchen and takes the tea leaves and make tea and drinks. This is known as psychological dependence or addiction. You know that this is inappropriate and this is not the right thing to do, despite that is continued use despite harm. And still you have the craving for that. So that is psychological dependence or addiction. And as you said, there would be headache, then tiredness, feeling of something is missing. This is the withdrawal syndrome. The body is showing due to the physical dependence to the drug, like to the tea. Because you have been providing the body with tea for so long and the body is used to getting it, but it is not being given. So the body reacts with this withdrawal syndrome. That is physical dependence. This is just to put it in simple statements that to differentiate between psychological dependence and physical dependence. So now this is my last slide. Dr. Hashmat has already given me warning that I'm getting over time. So this is just a comparative cost of opioids. So here it shows that tab morphine, a patient on tab morphine 5 milligram 4 hourly, that is a 30 milligram dose of morphine in a day. The cost is only 3.3 rupees 50 paise. The same equipotent dose of tramadol is costing 24 to 50 rupees. And the same equipotent dose of fentanyl patch, 12.5 microgram, cost around 250 to 400 rupees. And buprenorphine patch, which is 10 microgram, cost around 1920 rupees. And the methadone 5 milligram will cost only 4 rupees 50 paise. This is just to make you aware of the cost factor of different opioids. When you prescribe an opioid, please see the socioeconomic status of the patient also should be kept in mind while prescribing the medications. Thank you. Thank you all.
Thank you so much, Amirtha ma'am, for such a wonderful session, which was more enriched with practical learning. Thank you so much. And participants, you can come up with your questions. Maybe we can take for the next 3 minutes, and then we can move with the case presentation for today. If you have any questions, you can post in the chat box, or if you can raise your hand, unmute and ask, that is also fine. Maybe for the next 3 to 5 minutes, we can take up questions and then move with the case presentation. So, ma'am, Dr. Dilip is asking, is availability an issue? Morphine availability.
So all we need is a so RMI license is something which we need to procure that is available with the drug controller. So you can procure the license and the morphine can be procured from the drug controller. And we have our, like, suppose you are an RMI and you are in a status to procure the license, then there we have a facilitation team which is available in different parts of India who can help you with this. So we have regional facilitators who can guide you on this. Perhaps Dr. Farhana can send in your contact. You can contact them.
Yes. So we have our state facilitators working from different regions, the north, south, west, and east. And if you have an issue with procuring opioids, applying for the license and getting it, you can always reach out to them. The contact numbers of all the regional coordinators are mentioned on the website www.palliumindia.org, where you can go to the contact us section and everything is available there. And yes, definitely, as Dr. Dilip said, there will be a little bit of issue with procuring these opioids as different states function in different way. But definitely, we can help you in getting the narcotic license as well as the RMI status if you can reach out to us anytime. So, yes. Yes, Dr. Aditi has asked legal documentation. Yes, definitely we have different narcotic forms which need to be filled when we are dispensing opioids to the patients. And we have a session upcoming. Mostly it comes in July, where we will be talking about opioid availability, where it is a session which will be covering all the aspects of how to procure opioids and all of it. But there you'll be learning it in detail, Dr. Aditi. So, ma'am, Dr. Ravindra is asking, what is the first choice, methadone or morphine?
So I understand that you have a detailed class on methadone coming up next. First choice would be morphine, and depending upon the pain, like presentation of the pain and the type of pain, the choice can be variable, but mostly it would be morphine.
Dr. Shaimesh is asking, can we stop morphine directly or do we have to taper?
It is always well and good if you have used morphine for more than 3 weeks, it's good to taper and stop.
And Dr. Bindurani is asking, is double prescription required when prescribing from outside?
So as Dr. Hashmat Farhana has already mentioned, this will be variable for different states. So as she has already mentioned the number, you can contact them and get in touch with them and know the details on that. And I think even in your class on opioid availability, all this would be discussed.
Yes.
In detail.
Yes. Yes, sure. So I think in the chat box, we don't have questions as of now. We can move with the case presentation for today. I welcome Dr. Abhishek Kumar Nath for presenting his case today. Welcome you, Dr. Abhishek. Over to you. Dr. Abhishek, we cannot hear you. Can you please unmute yourself?
Am I audible?
Yes, yes, doctor. Please go ahead.
Okay, thank you. So my case is a 41 years old female with a diagnosis of carcinoma of buccal mucosa with paraparesis, L5 compression, compression fracture, epidural abscess, and grade 3 pressure sore at sacral region. The presenting complaints were moderate lower back pain for 3 months, bilateral lower limb weakness, more on right side for last 2 months, intermittent fever for last 1 week, and pressure sore over sacral and gluteal region for last 15 days. Coming to the pressure sores, it was in the sacral region. They were warm and tender. Exudation was present with redness and peeling off of skin. It was irregular in shape and foul smelling. The pain was in the lower back with gradual onset, aching in character, and tenderness over L5 region. There was radiation along both lower limbs with tingling sensation up to feet. Aggravating factor was any movement of spine and legs. Pain was continuous with no relieving factor, with an NRS severity of 7 out of 10. This patient was diagnosed with carcinoma buccal mucosa with skeletal metastasis and underwent chemo and radiotherapy in the oncology department of the government hospital. 1 month after radiotherapy, she complained of lower back pain, radiating along both legs up to feet, along with tingling sensation and gradual weakness. Within 2 months, her weakness progressed such that she was unable to move or sit up. After 1 month, she developed grade 3 pressure sore over sacral region. She was then referred to pain and palliative care department of the hospital for increased lower back pain, and leg weakness. She had difficulty in speaking and oral intake. Her sleep was disturbed. She was cachectic and intermittent low-grade fever for last 2 weeks. On examination, she was conscious and oriented with a temperature of 99 degrees Fahrenheit. Pulse was 88 beats per minute. Pressure was 110 by 70 millimeters of mercury. Respiration was 20 per minute. Other systems were within normal limit, but mouth opening was restricted with 2 finger breaths with difficulty in articulation of speech. On investigations, she had an increased total count of 22,000 per cubic millimeters and raised CRP of 24. Otherwise, all other blood reports were within normal limits. The PET CT showed skeletal metastasis. MRI was suggestive of L5 compression fracture with paravertebral and epidural abscess and cauda equina compression. Now, the psychosocial aspects of this lady was that she was a 41 years lady, completely bedridden, dependent on caregiver for even basic needs of urination and defecation. Her mother, a 79 years old lady suffering from severe back pain herself, is taking care of her. Her husband is emotionally and financially exhausted, having to take care of her medical needs and working for meeting the expenses. She has difficulty in speaking, so communication is very difficult for her, which has aggravated her depression and agony. As for medication, she was given intravenous ceftriaxone 1 gram for 15 days, an infusion of paracetamol 1 gram for 5 days, and then as needed. A tablet gabapentin was started at 300 milligrams thrice daily. Tablet amitriptyline was given 10 milligram after dinner. As for pain, initially she was started on tablet tramadol for 2 days, then shifted to tablet morphine, 5 milligram instant release, immediate release for 6 hourly for 3 days, then increased to 5 milligram immediate release 4 hourly for 5 days. Further dose increased to 10 milligram immediate release 4 hourly for 14 days, which offered some pain relief. So patient was shifted to tablet morphine sulfate, 30 milligram sustained release, 12 hourly, which offered 70% pain relief and was well tolerated by the patient. Other supportive therapy with antiemetics, laxatives, and calcium supplementation was given. Neurosurgical review was taken and an urgent laminectomy and discectomy was planned for this patient. The main concerns of this patient was pain. She was bedridden, epidural abscess, pressure sores, psychosocial isolation, and financial problems. In summary, a 41 years old lady with carcinoma buccal mucosa with paraparesis, L5 compression fracture, epidural abscess, and grade 3 pressure sores at the sacral region. That's all. Discussion points. How to individualize palliative care for this patient, what is the appropriate plan for post-surgical care, what is the maximum dose of morphine that can be safely given to this patient, what can be done for this patient and her family, what more can be done. Thank you, that's all.
Dr. Abhishek. Participants, you can also post your comments in the chat box regarding the discussion points. And meanwhile, thank you, Dr. Abhishek, for bringing such a wonderful case for presentation. I think she was a very young woman who had to undergo a lot of distress because of this such a serious health-related suffering with other comorbidities also which she had to handle. And based on the session that you have heard, so Dr. Abhishek, I would like to ask this question back to you. How would you have managed this patient in a much better way? Because you had started this patient on morphine, definitely you have done a very good job. But then regarding the question number 3, what is the maximum dose of morphine that can be safely given to this patient? So what would be your answer to that? And also if you want to comment on, based on the session you have heard and all of it, how you could have manage this patient in a better way. I think that would be really great to hear from you. And then we proceed with Dr. Amirtha's comments on the same.
As for my choice of management, I would have preferred some intermittent dose of morphine, that is instant release 10 milligram for breakthrough pain. Otherwise, the morphine dose can be given to 3 times daily if the pain wasn't relieved. Since we had a 70% pain relief, we didn't increase any further.
Thank you, Dr. Abhishek. And thank you for that patient scenario. Really, the patient and the family is having a really tough time. And you might also be finding it difficult to move forward with such a situation. I would like to hear from the participants especially on the third point, like what is the maximum dose of morphine that can be safely given to this patient? Any comments on that?
Actually, if patient is clinically stable and can tolerate, we can keep on increasing the morphine dose.
Pardon, sir, we couldn't hear you clearly. Can you please repeat?
Can you hear me now?
Yes.
So I think we can keep on increasing the morphine dose if the patient is stable and not having any side effect and can tolerate.
Thank you. Thank you, Dr. Dilip, for that. So I would like to hear from others also. What are your thoughts on that? What is the maximum dose of tramadol that can be given to a patient in 24 hours?
400 mg.
Thank you. Thank you so much, Dr. Raisa, for that. And so, as I've already mentioned during our session, morphine is a mu agonist drug. And since it's an agonist drug, even if you keep on increasing the dose of drug, the analgesic effect will also, there will be better analgesic effect. So there is no ceiling effect for the opioids. You can keep on increasing the dose, provided you keep a look or monitor for the toxic effects and the response to the pain. If the patient is having adequate pain relief, that means that it is responding, the pain is responding to the drug. And if that is the situation and the patient is not presenting with any toxic signs, you can keep on increasing the dose of the morphine. There is no ceiling effect for morphine. And to this patient, I understand that since the patient was having adequate pain relief, you have not titrated the dose. But otherwise, I would request if you could have gone by the clock. So the principles of analgesic use says that always go by the mouth, by the clock, by the ladder, and individualized treatment for each patient. So that is by the mouth means always prefer the oral route. By the clock means the frequency. So suppose the preparation is morphine, then it has to be given every 4 hourly. If it is a paracetamol, usually we prefer every 6 hourly. So that is by the clock and by the ladder. So depending upon the intensity of the pain, we can choose whether it is step 1, step 2 or step 3. And of course, individualized treatment depending upon the patient scenario. Dr. Raisa.
Dr. Raisa, would you like to unmute and ask your question?
Okay, ma'am. When the dose has reached 60 mg per day, we make it as 30 SRBD, right? So what if it exceeds to 90 and all? How will we give SR tablet?
So if it is 90 milligram, so what exactly we do is that the maximum dose in a 24 hours, if it is 90 milligram, then we can give 30 milligram thrice daily. 30 milligram of morphine, SR morphine thrice daily. So depending upon the maximum dose, you can you can divide and use the SR dose. So for us, sustained release preparations are available as 10 milligram, 20 milligram and 30 milligram, and 60 milligram preparations are also available.
Okay. So if 60 milligram is there, if it is exceeds, we can give 60 BD also, right?
Yes, if it is 120 milligram per day, it can
Yeah.
go up to 60 milligram twice daily.
Okay, thank you.
But in the next session, you will be studying in detail, you'll be learning about methadone, which would be another choice when the dose is going so high. And if it is a pain which is responding to the methadone, that you'll be learning in detail about methadone, and accordingly we can our choice of opioid will be depending upon that.
I hope that answers your question, Dr. Raisha. Any more questions? So here, how to individualize palliative care for this patient, I would say, Dr. Abhishek, you have done a wonderful job by assessing the patient's pain, the onset, the duration, all of this you have noticed. But then, as we learned in the session, Introduction to Pain, we always, as palliative care professionals, we look into the total pain concept. So we need to look into the emotional aspect, the emotional pain, the social pain, as well as the spiritual pain, and we need to address all those components together. So that matters a lot for this patient as well as for his family. So I wanted to add that point. And also here we were able to see that this patient had a pressure sore which was of grade 3, which definitely needs our attention, and we need to give the proper wound care management every single day, maybe twice daily. Dressing should be offered for this patient because right now she is going into a weakness, most probably because of the skeletal vertebral metastasis that she is undergoing, which is leading to the weakness, as well as this patient has become completely bedridden. So the care plays a major role in this patient, where you will have to advise them to give proper skin care, proper position changing in the bed, the airbed has to be provided, and for the grade 3 pressure sore, you have to give a proper wound care management, the pressure sore management, the dressing which has to be changed twice daily. So all of this adds to improved quality of care for this patient. Amrita ma'am, would you like to comment anything?
Yeah, so I would like to add a few points, like upon the 4th point, what can be done for this patient and her family? You have done a lot, but still I would like to add that in going through the psychosocial aspects, I understand that the patient is being taken care by a 72-year-old mother. I don't know about whether the patient is having children or any other supportive system. So one of the things that comes to my mind is if there is some possibility of including the volunteers or some other respite care mechanism for that family, where the mother can get some relief at least for some period of time, and you get an alternative solution to take care of the patient. That would be one thing which I would suggest. And as Hashmat has already mentioned, there are a few things looking into the physical aspect. We can do the caregiver education for the wound management, and of course the total care. A bit more deeper into the psychosocial aspect, how the husband, what the husband is going through, how the mother is coping with the situation, and how actually the patient is going through, because she has been facing a lot of things apart from the advanced cancer issues. She has developed a stage 3 pressure zone. So I would say we should explore a bit more into that and try to see whatever is possible, or wherever we can connect with the community and do something, try that aspect also.
Thank you so much, Amrita ma'am, for those suggestions. Dr. Kalyani, would you like to unmute and ask your question? Dr. Kalyani, you are muted.
Hello, am I audible?
Yes, yes, please go ahead.
Yes. So, ma'am, my question was, as morphine has to be dispensed only by the registered medical institution, can any doctor who is under under the Indian Medical Council can prescribe morphine, or he has to be having a separate license to prescribe narcotics?
So the question is not about prescribing morphine, but the question is about availability of morphine. So you cannot prescribe morphine, and any centers will not issue morphine as per your prescription. So unless you have some association with the recognized medical institution which has license for morphine, or where morphine is available, because this is not readily available in pharmacy. So prescribing wouldn't be a difficult part, Dr. Kalyani, but the procurement of the medicine, like the patient will not be able to procure this medication from unless there is an RMI, or there is a place where this opioid is available and they understand that you are a qualified medical professional and in time. Otherwise, they won't dispense. They won't give the patient the medication.
Yes, so adding to that, Dr. Kalyani, the NDPS Amendment Act of 2013 actually says that a registered medical practitioner should have a basic training to dispense these opioids or to write prescription for oral essential narcotic drugs. That is the first criteria. And then you have to have a recognized medical institution which has the license to procure these opioids, the oral opioids that we are giving like morphine, and to dispense it. Only both these things are there, you will be able to dispense the opioid from your end. So
Okay, ma'am.
we will be dealing it in the opioid availability session.
Okay, ma'am. Ma'am, so is this training, can this training qualify us for prescribing morphine? Suppose say we have a registered medical institute. Will this training be enough for us to prescribe morphine?
Yes, definitely, Dr. Kalyani. The certificate that we provide will be adequate for you to, prescribe morphine. Definitely, for sure.
Okay, and one more thing I had in mind was, when we are prescribing sedatives right now, we are not prescribing for more than 15 days. Even the pharmacies, they say that the patient has to renew the hypnotic or the sedative prescription. So is it the same for morphine as well? Is there a validity period, like number of days or number of milligrams of morphine that has to be prescribed during a certain period of time?
So I would say that Dr. Kalyani, kindly note down these questions and keep it with you. And when it comes back to the opioid availability session, definitely we will take it up.
All right, ma'am.
A discussion on that. Thank you so much.
Yeah, thank you so much.
This is very different for different states. So, yeah, it would be the right time to discuss that.
Dr. Abhishek, I could see that you have posted a question in the chat box. Would you like to unmute and ask?
Ma'am, in the case scenario, this is actually a problem we have been facing, that after surgery, the patient will have acute post-surgical pain. So how to manage that in presence of morphine? Already the patient is on morphine. So any dose changes or any other thing that is required for me?
Yes, Dr. Abhishek. So, of course, depending upon the intensity of the pain, we need to increase the dose of morphine. And the only thing that we need to watch for is if the patient is having response, like depending upon the scoring, intensity of pain, if the pain score is reducing, and if the patient is developing any toxic signs. That would be the 2 points that you need to check while titrating the dose of morphine. So if the pain is more, you need to increase the dose of morphine and monitor if the patient has adequate, the pain response is improving, and if there is, look for any toxic signs also like drowsiness, myoclonus or delirium, any such signs are developing. If at all there is some signs developing, then you'll have to maybe you can skip 1 or 2 doses and then slowly reduce the dose. That indicates that the pain is not a nociceptive kind of pain which is responding to morphine. If not, you can very well increase the dose of morphine.
Okay, ma'am. Thank you so much.
Thank you.
Any more questions? I hope all the questions in the chat boxes of now have been answered. If you have more questions, you can post. We have 2 more minutes. Or even you can raise your hand. So, okay. So if there are no more questions, I think we can close the session for today. I thank Dr. Abhishek for bringing in a wonderful case for presentation. I wholeheartedly thank Amrita ma'am for joining us via Echo today. And it was really nice hearing to her after a very long time. Thank you, ma'am, for such a wonderful session. Thank you all the participants for being really, really very interactive during the entire session. And handing it over to Gayatri.
Thank you, Dr. Amrita ma'am and Dr. Hashmad ma'am for the wonderful session. I hope the session is enriched with much of knowledge and insights of management of pain. Thank you all for the participation and your time. We are looking forward to see you on the next session. Thank you all.
Thank you.
Thank you. Bye-bye.